Alistair, you are the National Clinical Director for Dementia, but you still work as a Professor of Old Age Psychiatry in Manchester. What changes have you seen in your clinical practice over the last 2 years?
I think in my practice I run a memory clinic in South Manchester, and I'm an old age psychiatrist, so I'm responsible as well for the assessment and diagnosis of a group of older people who have mental health problems of any cause. I think for me the awareness of dementia is the thing that, if I reflect over the last 2 or 3 years, there has been a great increase in terms of people being interested in coming forward, knowing more about dementia, and generally, not necessarily in the last couple of years, but if we were to look at a slightly longer time scale, people coming much earlier in the disease. I remember when I started as an old age psychiatrist, and I'm sure Mark, you would see this as well. Often, to see someone at home in a crisis, who clearly had a dementia for a number of years, but people coming a lot earlier, not just people themselves, but being brought by their families, in the understanding that there are things that can be done for people with dementia to support them. And for me, that support is so important. A question I'm often asked is, well, what's the point of diagnosis, because there's no support out there? We know and we acknowledge that there are examples of a very good practice of post-diagnostic support that is often led and run by the local authority, the councils, the voluntary agencies, but certainly in areas where I have had the privilege to go and see, there is a very active post-diagnostic support. And for me, an example might be a dementia advisor. And I've used the analogy before of Mr. Smith. He's in his late 70s, and one Saturday night he suddenly becomes quite agitated and distressed. His local GP is called, and an out-of-hours general practitioner comes to see him. There's not a lot of information around, and it looks as if he's got a urinary tract infection and a confusional state. And because there isn't a lot of support out there, the only thing that can be done is to admit Mr. Smith to hospital. When he's admitted to hospital, it's found that he's had symptoms of memory loss for a couple of years. A diagnosis of dementia is made. Because he's agitated, he's sedated, he falls out of bed, breaks his leg, and is discharged to a care home. Now, that's what can happen. What could happen in an ideal situation is that if he had had a diagnosis of dementia a couple of years ago, both he and his wife could have had access to a dementia advisor. They would have given support and information. And you can imagine a scenario that one Tuesday, Mrs. Smith notices her husband isn't quite himself. He's been up to the toilet a couple of times during the night, which is unusual for him. She speaks to her dementia advisor, who says, "Do you realise people with dementia are 10 times more likely to get confused if they get a physical illness? I think you should go and see your GP." So Mr. and Mrs. Smith see their GP, who knows Mr. Smith very well, agrees that it might be a urinary tract infection, prescribes an antibiotic, and Mr. Smith doesn't need to go to hospital. Now, that's just a very kind of simple way, but for me, the post-diagnostic support is the thing that has changed things for me. So, sorry, that was a long-winded way to go back to your question about what difference I've seen in my practice. It's people being more interested in dementia. It's people coming forward, but it's also my colleagues. I think awareness of dementia has never been at its highest, but the responsibility now is to change that awareness into doing something to help people with dementia and their carers. At one level, that might be finding a cure, but at the other end of the spectrum, it's that post-diagnostic support that people get immediately, and that was the raison d'etre of the diagnosis rate. It was because when we started a number of years ago, less than half of people, in some areas only a third of people, got a diagnosis. they would often present in crisis. So it's getting that post-diagnostic support in. It's using the diagnosis rate as a vehicle to access high-quality post-diagnostic support. But I know a challenge, Mark, you and your colleagues have given me, is how we measure that. And that's something that we're thinking of. And if you or your colleagues have any ideas or thoughts on that, please write to me, alistair.burns@nhs.net, and I'd be really pleased to hear.
Thank you. That was a really clear example, and it was interesting to hear the case you presented. Thank you very much, Alistair. Thanks for coming to Lincolnshire.
Thank you very much, Mark.